practice among manual therapists and mitigate risks for therapists and their clients. My name is Rod Diaz. I'm the membership manager of FOIT, which is an independent association of some 5,000 therapists and practitioners engaging in some 1,600 modalities across 31 countries. Our 3 levels of membership enable us to offer support for the beginner to the experienced practitioner. This webinar is hosted by FOIT and also BGI UK and BGI EU, who offer bespoke insurance for therapists and practitioners worldwide. It is my great pleasure today to welcome our panelists. We have an osteopath, a chiropractor, and a physiotherapist in Robin, Danny, and Ashley, and I will invite them to introduce themselves, starting with Robin, please.
Hi, thanks, Rod. Good morning. Yeah, I was just going to say, I've been an osteopath for about 34 years. I'm a clinical educator, postgraduates to chiropractors, physios, and osteopaths. And also I do some leadership coaching, which I've found very interesting for my career as well. So yeah, that's what I do. Welcome, Robin. Thank you. Thank you.
And Danny?
Hi, I'm Danny. I'm a chiropractor from Bristol. I'm a Bristol Chiropractic Sports and Family Clinic owner. I've been a chiropractor for 12 years. I specialize in sports but I live in Gloucester, weirdly.
Welcome, Danny. Thank you. And Ashley?
Hello, I'm a physiotherapist in Cambridgeshire. I work predominantly in MSK sports, really. I also work in an orthopedic hospital as well. And I'm an athlete myself, former Olympian. So yeah, that's what I do really day to day.
Thank you, Ashley. Would you like to expand a little bit on your Olympic experience?
Yes, so last year in February 2022, I took part in the Winter Olympics in the sport of bobsleigh, and I competed for Team Jamaica in the 4-man bobsleigh event. So cool runnings, basically.
Wonderful. Thank you very much. And welcome all of you to this webinar. So today we're going to be basing our discussion loosely around research undertaken by the National Council for Osteopathic Research, or NCOR, and they conducted a study between 2013 to 2021, which is a good 8-year piece of time, on the types of concerns and complaints raised about osteopaths and osteopathic services. So although this study relates to osteopaths, it can relate to all types of manual therapists. So it's a very interesting study, and it raises a lot of issues which we can talk at length about. The study was conducted by Dr. Dawn Carnes from the University College of Osteopathy. From that study, we can find a number of areas of concern specifically for 2021, the most recent year of the study, where it was found that there was no diagnosis or an inadequate diagnosis from many practitioners. There was a failure to refer. There was a failure to maintain professional indemnity, interestingly enough. Communicating inappropriately was an area noted of concern, sexual impropriety as well, and of course complaints about conduct bringing the profession into disrepute. And if we look at the chart, which highlights the number and types of concerns and complaints, we can see there at the top in orange that clinical care issues have been a major concern over the period of time, as have relational issues in yellow. Although there's been a steady decrease generally over the last 8 years, we look at 2020 to 2021 and there's starting to be an increase as well. So certainly the issues and the problems haven't gone away. So these are the areas that we'll be focusing on, particularly clinical care issues and also relational issues. So part A, there are 4 parts to our discussion this morning. Part A is communication and patient partnership. And this theme sets out the standards relating to communication, the formation of effective patient partnerships, and consent. Now, consent is an issue which we'll be looking at in greater detail later, and there are a number of themes and subjects which transcend these areas. So we will be going backwards and forwards a little bit, but that's the nature of the subject that we're talking about this morning. What we are going to be looking at specifically is communications with clients and appropriate dialogue. And the NCORE findings have found that there has been a basic failure to communicate effectively and communicating inappropriately. There is one example about rude remarks about weight, but other examples of inappropriate communication have included inappropriate or unjustified comments about pregnancy related to the COVID-19 vaccine, which is slightly historical now, but that was fairly recent, and inappropriate comments that were construed as racist. So rude remarks about weight is one area that we can look at. If we look at the first chart on this area, we have failure to obtain valid consent, no shared decision-making with the patient as a major area of concern. This will be referred back to, this chart will be referred back to later when we talk about consent in more detail. Communicating inappropriately clearly is an issue there, and a failure to communicate effectively. At the bottom, you can see that healthcare staff disregard or do not acknowledge information from clients, which was an interesting observation. Absent or incorrect communication from healthcare staff to patients was also another noted observation, which is of interest. With regard to respect and patient rights, this is before I start asking questions of the panel members. We'll have a quick look at this area. Failure to protect the patient's dignity and modesty has clearly been an issue. Sexual impropriety is clearly the major issue there. Conducting a personal relationship with the patient and also failure to treat the patient considerately or politely has been an issue. So how do panel members communicate the risks of manual therapy effectively with their clients? Could I ask maybe Robin to kick off, please?
Yeah, sure. I think what's important to contextualize this, I suppose it's important that professions do take these things really seriously. And clearly the General Osteopathic Council and particularly NCORE in this case have done a lot of work to produce these sort of statistics. And I think everyone can learn from those, as we're hopefully going to do today. I think the way communication is done is something that starts at the undergraduate level, and people work with that all the way through their careers. And if they're reflecting thoroughly, in a sense, on how they interact with their patients to get the best outcomes, to get compliance so that people are happy to follow out suggestions and advice which are discussed, it's really important that the clarity is there in the way professionals are dealing with their patients or clients, as you put them as well. So I think all of these things about respecting rights is critical for everyone to bear in mind. And obviously these cases are luckily and thankfully the rarity where people are perhaps, well, not perhaps, they're not behaving according to standards that many people would say are normal practice in everyday life, let alone as a professional. But nevertheless, that communication level is so important to make sure that there aren't concerns that arise, and indeed there aren't any misconceptions between patient and professional. I don't know if that answers your question, Rod.
It does, thank you. It certainly does start off the discussion. Danny, would you like to add anything?
Yeah, I think Rob makes a good point that it's a process that occurs over many years. In some, to perfect in some ways. We do describe it as patient management. I'm even now, there's times I'm not happy with the way I communicate, so I work on that, constantly reanalyzing how I approach different situations. As far as how we communicate actually in the clinic, risks in particular, we have a two-step process where we have a form which the patients read before they sign the first stage of consent before they're examined, and in there is the risks and what's about to occur. And then when we have the second phase, when actually with the chiropractor, the chiropractor then explains the risks of the treatment plan that's about to occur following the examination, and the risks are again explained at that stage. So there's a two-step process. So there's one before the examination and one after the examination, and it's all recorded and signatures are taken before you proceed. So it's almost like a double backup system there.
Thank you, Danny. And Ashley, would you have anything else to add to this area of discussion, please?
Just to add on from Danny and Robin is, yeah, really getting that trust of the patient, and you know, providing them with the risks and benefits of the manual therapy or whatever you're about to do, and just being honest with what you know. And if they ask questions and you don't know them, don't pretend you know them. You just got to be really honest, and you can even kind of reflect on experiences with patients with kind of maybe certain comorbidities or similar patients groups, and just communicate well at assessment and before the intervention as well. And if it's going to be more, I guess, of a risky intervention you're going to do, then make sure you explain that in depth and get some consent as well. So written consent when it's more risky, I'd say.
Actually, could I just add something to both of their comments? I think that sometimes it's going through the sort of the motion. It's not motions, it's going through that kind of checking of people understood, but sometimes it's very important to check that person's really switched on and listening, because it's a different story saying it, but are people really getting it? Are they really understanding things? And some patients may even say, I don't really want to know, just get on with it. But actually that ain't really good enough in terms of making sure they've grasped what's going on. So I think I double check that with people as well, that they've really, even that they repeat back to me perhaps what's going on, so I know that it's gone in.
Yeah, I agree with that, Robin, because a lot of people interpret things much differently to what you've said. So yeah,
sometimes you can feel pressurized as well by them to press on to the next stage, whereas you really need to make sure you cover yourself.
Yes.
Yeah, so getting feedback, ensuring that the message has been understood and interpreted properly is really key here, I think. And healthcare staff at the bottom of this earlier slide disregard or do not acknowledge information from patients. That's part of the two-way process of communication, where the therapist, really does need to listen in order for the message to then get correctly, delivered back to the patient, so that everybody's on the same page, everybody's understanding where you are at. I would like to ask panel members, how do they ensure that the communication is appropriate? So dealing with that example as weight, dealing with the patient's weight as an example, because obviously, it's not rocket science that the heavier a patient is, the more weight and therefore stress is on the body and the limbs, but that's clearly a sensitive area. So how would panel members ensure communication is appropriate when dealing with this tricky area such as weight? That would be interesting to find out. Would anybody have anything to add to that? Maybe Robin, would you start?
Yeah, I mean, I think is getting that level and keeping that respect and distance is making sure, and we call patients. Some people refer to them as clients. I think it's very much keeping that professionalism at all stages and keeping that distance. So that distance enables you to ask them a little bit about how they're feeling about certain issues. And one might be how they feel about their weight, or do they feel it might be a contributing factor to their condition. So you're asking them questions, really opening things up rather than telling them how it is. And I think that's a way round that can at least open discussion. And really that's where they may come to their own conclusions, and they may offer how they feel about it as well then in that conversation starter. So that's the way I tend to go about it if I think it's relevant to their case.
Yes, and I've heard that it's sometimes the case, or maybe even often the case, that the patient or the client themselves will bring up their own weight during treatments. So has that been your experience, and how would you manage that? Ashley, I don't know if you have anything to add to this.
Yeah, so just like you said, it is normally in my experience is if a patient, if there is a slight weight issue, the patient tends to bring that up. But if they didn't and it was relevant and I wanted to speak about it, I'll just open the discussion in respectful, non-judgmental way. Because when patients feel more respected and you're respecting the patient, it's gonna probably be a more kind of discussion. And I would always use the terms like weight or BMI, as opposed to saying obesity. You've got to be really careful with the words you say, and the thing is why that's difficult, because different kind of cultures as well as different ages may find certain words a bit offensive or impolite. So you just got to be really careful. And I feel like even when you do talk about kind of weight, you have to have that really good relationship already built up. So it might not be something you bring up straight away at all. we need to build that relationship first.
Right. Danny, thank you, Ashley. Danny, would you have anything to add to this discussion?
They're brilliant points to make. And the thing I was going to bring in was generally looking at communication. I always remember from university that them saying try to avoid certain subjects if you can. So try not to put yourself in that position where you could make a mistake in the first place. Things like gender, politics, and religion were kind of three topics I always remember. If it comes up, so if the patient brings it up, be aware of the sensitivity of the topics, but also if possible, try to avoid, if you can, the going into those topics and leading yourself into a position where you could say something incorrect, because they are very, very sensitive sometimes.
Right, thank you very much. I think we'll move on now to part B. Knowledge, skills, and performance. All practitioners must have the knowledge and skills to support their practice as primary healthcare professionals, and must maintain and develop these throughout their careers, such as attending continual professional development events, such as the one we're talking about today. Here we're going to be looking at specifically dealing with difficult clients and the perhaps tricky subject of offering compensation. And ENCORE findings are that providing advice, treatment, or care that is beyond the competence of the practitioner or the modality itself of osteopathy or physiotherapy has been or is an area of concern. So what do panelists, or how do panelists manage day-to-day risks and potentially difficult clients? And do they have any examples of this? Ashley, I don't know if you could start the discussion on this area, please.
Yeah, so difficult patients, I mean, it can mean a lot of things, I guess, but really it's just being very alert, and I don't really have much examples of myself where I've been in a real bad situation with a difficult client, but I just tend to again build that relationship, be respectful, and anything I do, I really do explain why I'm doing this, what their thoughts are, they open with this, and see how they react, and just have a nice discussion and really focus on the subjective assessment before doing anything. Really, I want to get as much trust and understand this patient as much as I can before doing anything to them, and making sure they have a really deep understanding of what I'm trying to do, and just building a really big relationship, really.
Excellent. Thank you, Ashley. Danny, have you had any particularly difficult clients in the past, and how have you managed them?
Yeah, quite a few. So I think I was just thinking then, there's two things I'd probably mention. One is set expectations from the beginning, and then reset those expectations as things change throughout the treatment process. That really helps decrease risks. For example, a patient recently came from having seen another chiropractor in another country. And what I always tend to do when you have a patient who has seen someone else, especially if they've been in a similar profession, is to set the expectation that the treatment is likely to be very different, or it could be similar. But just to make sure that they are aware that it could be different, because there is no set scope of practice across the individual professions, so that it can vary quite a lot, just in case. Because if they're expecting one thing and they come and get something different, they can be quite upset sometimes, and feel like they've been they're confused, and so they feel like they've been not mistreated necessarily, but just not given what they've paid for. And the other part is knowing your limitations, so what you can and cannot achieve. And so for example, I wouldn't say it's a difficult client as such, but I had a patient come in who so I've had fractures coming in the past, and it's knowing what to do in those situations, and you have to evaluate correctly, and then move them on appropriately. And when you have injuries where you can't help the person, then you know that you have to pass them on and refer them to the correct person.
Excellent, thank you, Danny. Robin, have you had any experience with dealing with difficult clients, and what's your take on offering compensation if compensation is asked for?
Okay, well, first of all, difficult. I don't use the word difficult, and I think over experience has taught me to say that the person is probably and likely worried, concerned, in pain, has been through the mill, whatever you want to call it, and has suffered. So largely, if people are presenting as perhaps awkward or difficult, it's really to get a bit of insight on that, to find out how they're feeling, what's going on, because that emotional side to that, I think, is quite helpful as an insight, and that actually might put them at ease in a different way and allow them to share with you in a kind of different way. So you're going to get a different case history, you're going to get different information out from them. And I think, as Danny said, in fact, what can happen is people could have seen a physio, chiropractor, osteopath before, or a different osteopath or a different physio, chiropractor before as well. So their expectation, I think that's quite important, is that, they may be wanting something they've had before 10 years ago because it worked, or they've, seen someone who insisted it was X rather than Y as the problem. And, we're dealing with each case by case. Trying to instill in people that we do need to go through our own assessment as a professional and check that what we're doing is appropriate, and it may not be what they're expecting exactly. So we need to negotiate that with some people more than others, is really important. And so obviously getting that right can help reduce the chances of someone saying they're not happy and compensation question. That was your point to me. And I think the key part about that is really, I think probably admitting liability at that point is a problem, and actually offering compensation is kind of going along those lines. So it's not something that I would entertain. If people want my time and they want my professional opinion, then that has a value and that has a cost, and that's the contract, in a sense, that I'm forming with my patient. So largely, that's fortunately hasn't come up as a particular issue. But I could see people might fall into that trap, that giving money back or whatever it is or compensating in some way. But I think that can lead you up a garden path and perhaps also undermine your confidence as a practitioner. I think if you're being a practitioner and you're managing the case, managing the patient and their expectations really well, then it shouldn't really come into that kind of domain where, one had to offer that. That's my experience view, I suppose.
Yeah, thank you, all of you. I think managing patient-client expectation is really important. Maintaining those communication lines, making sure that the communication is two-way. If they've had a previous consultation, then making sure that you go into some detail and depth as to how that went and what you could be offering, which is similar and or different to that. That's all really good. But what would you do if a client or patient wrote to you and said, I would like to be compensated for the hurt that you've caused me, or the treatment that hasn't worked? How would you actually manage that if somebody formally wrote to you and asked for compensation?
I was going to say, every clinic should have a robust complaints procedure put in place, right, anyway, which should on our website, and we have it stated on there about how we acknowledge the receipt of the complaint within 2 days, and then after 10 days we will reply, and it's in writing. And so again, it's a barrier for you to, or a time frame for you to then for you to be able to put together something robust to defend yourself using your written policies that you've got in place that the patient should have been exposed to, ideally in preparation for their treatment. I remember Robin told us a good story about an episode he had where a patient wrote in, and it sounded like he dealt with that really well.
Well, I think I might as well, Danny, come back on that actually straight away, because I think people do perhaps put things in writing and they feel frustrated. And I think having a conversation or exchange of email that carefully explores their feelings and what's going on is certainly a good step. I think also giving people forewarning that, they may be sore, they may have a reaction. Indeed, the reaction or what they're feeling may have nothing much to do with the actual appointment at all, but often people want to attribute blame. So it's handling that very carefully. And I think, reflecting before replying is very, very important. Having that time to sort of feel, it actually feels, perhaps sometimes that you're being attacked and threatened back by the patient or the statements that are being made. And I think it's quite important to cool off and think about it carefully before responding. And if necessary, I think, mention it to your regulator, mention it to your insurer, so that everybody's on the same page, that at least if something might transpire or may not, I mean, quite often it doesn't, but if someone does have an issue that you think might go further, it's probably worth just kind of mentioning it to the relevant parties, insurer and regulator, just so that that's being covered. I think that's a wise move.
Yes, and thank you, Robin, and thank you, Danny and Ashley. I was going to ask, actually, you know, would you inform your relevant professional associations, bodies? Would you inform your insurer when you do, you know, receive a complaint, a formal written complaint, and/or a request for compensation? And I guess you'd look at the actual complaint or the request itself and make that decision accordingly at the time.
Well, most people are looking for a response in the initial phase to be acknowledged. I think most of the insurers and people I've ever spoken to when I've done courses with others on this very topic, it's very much explore what's really being said, because most people are not necessarily making a case out of it to start with. They just want acknowledgement, and they just want to explore what's gone on, and they need that to be talked through. So that's a step that I think is worth doing before, you know, assuming it could go much worse.
Right. So yes, engaging the clients and finding out what is, you know, really at the root of the request for compensation, and then seeing if it can be talked through and talked, you know, and reconciled. I guess reconciliation is the key word there. So that's great. Thank you very much. And moving on to this next topic now. It's quite an interesting one. This is part C, safety and quality in practice. Practitioners must deliver high quality and safe healthcare to patients. This theme sets out the standards in relation to the delivery of care. We're looking specifically at consent guidance and consent forms, 16 to 18-year-olds, and different areas or parts of the body. Now, underpinning this whole area is the concept that consent is a process and not an event. So it should be viewed as a continuing and continual process where it is constantly revisited and reassessed, and basically the onus is on the practitioner to ensure that the patient, the client, consents to each and every session or part of the treatment that's being administered, and consent is what we call it informed, is termed, the client is fully aware that they are consenting to this particular type of treatment and why they would do that. And so if we look at quality of care in terms of the research that was done, we'll also look at a case study in terms of there's one from the General Chiropractic Council, which we'll look at, which goes into quite graphic detail the issue of consent, and particularly informed consent in terms of treating a patient. But here we look at the quality of care in the research. The termination of the osteopath-patient relationship is one of the minor ones, but the health of the osteopath, which is quite interesting, to deliver the care was found to be higher than others, but we're not going to be focusing on that. Breach of patient confidentiality, we're going to be dealing with probably a little bit later, but no treatment plan or an inadequate treatment plan is something of concern. The big area of concern is that there was no diagnosis, or the diagnosis was inadequate. And inadequate examination, insufficient clinical tests was an inadequate case history, which comes down to how well you know your client and how much communication there has been on the background. So that's the quality of care issues. And then if we move on to safety of care issues, here we can see that the treatment causes new or increased pain or injury is the major area of concern. So person goes to see a manual therapist, and within one or two treatments, the pain has actually increased, or the injury has actually increased, or there's been a new injury, is an area of concern. The treatment administered incompetently has been an area to look at. Forceful treatments, and of course, inappropriate treatment or treatment not justified is an area. And this will relate to one or both of the case studies that we'll look at in a moment. So moving on to one question here from one of our participants: what is the best way to communicate to a patient they might feel worse for a period of time before they feel better, as is, I think, and I understand, often the case with manual therapies, and how best to follow up with that issue? Is it a phone call, a text, or an email? And do you use your personal phone or your work phone? And this obviously relates to this treatment causes new or increased pain or injury aspect that the research has unveiled. So, Danny, going back to this question, what do you think?
So what I tend to say to each patient at the end of their report of findings or during the report of findings is that there are expected in 30 to 50% of patients, there will be some kind of treatment reaction to varying degrees. And we also look back at our previous risks that I've explained in the past. So on the sheet of paper I said before, the two-step process, I allude back to that and make sure that they've read it. And then if you bring any new treatments in throughout your plan of management, you also want to make sure you cover the risks of those, and that the patient, again, may feel sore or in 30 to 50% of the cases with those new treatments as well. We also have a follow-up system. We call it a courtesy call for each new patient. So the next day they get a call from the reception team asking not how they are, but were their questions answered? Because if they're asking, how are you the day after they've had treatment, in a lot of cases they'll still be sore. So it's a kind of a silly question in some cases. So, but you're just checking up on them. Were all your questions answered? Are you happy with the care that you received? Then there are other options in our profession. We have a patient-reported outcome measures, PROMs. There's a system called Care Response, which you can sign up to, and patients receive an email every 2 weeks. I think it's 6 weeks, and then after, I think it's another period of time, maybe 12 weeks, they get an email, and it has a questionnaire, which then summarizes it into various different percentages, which the clinician can look at to see improvements, and the patient can make comments on how their care has been as well. So it's quite comprehensive.
That's great. Thank you, Danny. Ashley, do you have anything to add on this particular question from one of our participants?
Well, the only difference really from Danny is, you know, I tend to kind of explain the risks like we should be doing anyway, and before the well, after the assessment, and then I like to just draw on personal experiences as well. And if I know any good literature numbers in my head, I'll say literature says this many blah 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 blah, and just to give them a few different kind of what I've experienced, what literature says, and what I have to say. And follow-up wise, I do always, me personally, I always say to my patients, you know, if you ever get these reactions at any point, or if you're concerned, you're free to call me. And I do use my work phone, not my personal phone. I don't mix my personal and business at all, really. So, and that's how I would do it.
Thank you, Ashley. It's interesting. You'd share your own experiences of being an athlete and also getting treatment. And certainly my own experience of being an athlete and getting treatment is that very often it feels more painful after treatments, certainly the first few treatments, than it did before. But that's part of the healing process, isn't it?
That's it. And as well as experience, I mean, like experience of, yes, me being an athlete, and also what previous patients have kind of fed back to me, because I always try and get feedback from all my patients as well, because I think it's just good for them to know. Yeah.
Excellent. And then referencing materials, sort of academic, industry materials that back up what you're saying.
Yeah, I think that's good as well. A lot of my patients are kind of like me, a bit nerdy like me, so it's always good to try and go to their level and give, you know, this literature actually says this, so this is what I know.
Thank you, Ashley. Robin, do you have anything to add to this particular question or these questions?
Yeah, actually, I think certainly what Ashley said about keeping your work and personal phone separate, I think is an absolute imperative in terms of running a practice, because, you know, that accessibility and that instant accessibility of, you know, emailing and texting and stuff, it can become quite hard to handle, especially if someone's got a concern. It doesn't mean you don't want to get hold of you, but it just means you need that little bit of a space in between. And I think probably, again, as mentioned by both, you know, that feeling that if they're concerned, they've got somewhere to turn, because obviously they may be sore and you've explained that and they may feel a bit achy or whatever. I think probably just setting the ground to say, if you're concerned about it, by all means get in touch, because I think it can be expected they may feel something and that can be explained. But really, if it's worrying, that's where it comes into being a problem. And I suppose letting them measure improvement and change. I think at every session, it's certainly my practice to ask how people are progressing, were there any downsides from the treatment, what were the upsides from the treatment. In other words, they might say, well, I felt a bit sore, but now I feel much better, or my mobility's improved, but I'm a bit sore somewhere else. So there could be, there could be all sorts of things that kind of come to mind during the time in between sessions. I think that's quite important. And taking the time out during that session to have that conversation is a valid part of that session. It's not wasted time to find out what's working, what isn't, what worries them, and to keep doing that all the way through the process. So yeah,
absolutely. Thank you. What's very apparent to me is that all these areas and these different sections are inextricably interrelated, so that the way that we communicate, how we build up rapport with our patients and clients is really important, so that managing any risk and pain management, if you like, with the treatments is really important, and it's integral, and it all comes down to mutual trust between practitioner and client, and this starts from the very, very beginning, and it really is dependent on how deeply you engage and how comprehensively you engage with the client from the get-go, finding out their past history, whether they've had treatments before, getting to know them, and making sure that the communication is two-way all the way through, and that consent therefore remains the process all the way through, rather than a single event, which is great to confirm. Moving on, we have, before I ask general questions about consent, I just want to refer to the General Chiropractic Council case, which occurred in 2016 but has been dealt with recently, and it's based on a consultation with a 20-year-old female patient who was feeling neck, back and hip pain. During the first consultation, the practitioner undertook vaginal and anal examination of the patient, and during that internal examination asked inappropriate questions. So the General Chiropractic Council's investigation revealed that there was actually no medical justification for this examination, this internal examination, and there was no explanation from the practitioner. No time to consider the examination was given to the client, and there was certainly no offer of a chaperone. Now, I'm not going to go into any more depth into this case unless we decide to discuss it in further detail, but I just want to set that as a case reference for the issue of consent and the seriousness of the issue of consent before we go on to the next questions. So with this and all other previous findings in mind, and also going back to the figure 8A, which we looked at earlier under part A, the failure to obtain valid consent at the top there, no shared decision-making with the patient, critical issue which has been identified as an area of concern. How do panel members manage consent generally? So, Robin, could I ask you to maybe start this off first?
Well, I think probably should say
very general.
Well, I think just to go back to the previous screen, I mean, I think it's key to say that these are aberrant and against the law behaviours in every sense, and in a sense that goes without saying that these are luckily rare. Obviously, you want to avoid confusions, complications, and things where where it is done in a well-meaning and professional manner. This clearly wasn't on it. Probably on any level, which is sad, and all practitioners, as we learn and have CPD and share things together as we're doing now, in a sense, we all know where people work professionally and are considerate and treat our patients, with the right respect they deserve. So this is obviously upsetting for any professional to read. I don't think any of us, take it particularly by profession, but it's it's not how it should be. So obtaining consent, I know some people do take written consent, but I think a lot of the time it's important. This reflection process you know, and choosing to do things in a particular order. For example, I think the case mentioned had a neck problem as well as other things.
Yes.
So perhaps it might have been appropriate to choose other areas to treat first, you know, which would have been a reasonable choice. So, you know, trying to communicate appropriately, again, as we said earlier, it's really finding out if the patient's really understood and is really listening and hearing what is being explained, and having the chaperone. You know, I often, if it's an elderly person or anyone who might have another person in the room, it's a really useful tactic, because in a sense, you've got someone else there as an advocate for them, not just a witness and a chaperone, but someone else who might actually guide and help and give them someone to discuss what you've explored and explained at a later time with that patient. So that's a, you know, a huge benefit. And people do ask me, you know, can I bring in my husband? Can I bring in my daughter? Whatever it is, you know, and I'll say, sure, absolutely. There's nothing to hide here. So, you know, that's an open approach to letting people, you know, share the process with someone they trust, you know, who they know and trust. And they can discuss even in front of me whether they're fully happy, fully understand, and so on. And that's a really useful part of the process. So you may as well take every possibility out of the chaperone example and make a better form of practice out of it.
Thank you, Robin. That's very, very helpful. Danny, would you like to add your experience in dealing with consent generally? And you may, you're free to make reference to that case, but please provide your experience and knowledge on consent generally.
So the case in point, I think the main takeaway for me was that really you should only be performing things that you've been taught, because that's ultimately the justification. So there are some internal examinations that do occur if you've been taught them in chiropractic. One is a coccyx adjustment, but a lot of clinicians, majority of the clinicians, don't actually choose to learn that technique. The other takeaway was actually that if you look at the case, they didn't give the patient enough time to consider the consent, because she actually, at the time, she did obviously allow it to happen, but what was determined was that it wasn't enough time for her to consider the whole situation before it was taken, the procedure was taken through. Not that I'm trying to defend it or anything at all. I'm just this is the way the council looked at it objectively. The other thing is capacity. When it comes to consent, you want to make sure, if you're dealing with individuals who may have dementia or are young, you want to make sure that you determine they have capacity, and that's the key word when it comes to consent, that they can actually make that decision. But what has, like I say, come to light recently is this need for time as well, and if you do feel that the examinations are risky as such. Yeah, but that's such a rare, such a rare case, that one.
Thank you, Danny. I appreciate your input. Just to pick up on a point that you made, that this type of internal examination requires additional training and additional qualifications.
Yeah,
is that right?
Yeah, it's a really. When I found out it happened in the chiropractic profession, it was quite surprised, but it's something that does happen. It's a technique which is used. You can choose, like I say, to learn it at university level, not only at one of the universities as far as I'm aware, and only a select amount of people choose to learn it, and you do have to actually practice on colleagues and friends. So it's quite I mean, you can imagine what kind of things are said about that, because it's
quite invasive. Yeah,
invasive. Yeah. It's but ultimately, again, consent. If the person is fully informed and determines that they're happy for the procedure to be carried out, then it happens. I mean, it happens in GP practices. You know, things have to be examined internally there. But it's whether or not it's and this is where, in that case as well, there's two experts brought in. One agreed with the fact that it was required for the examination based on the symptoms that were experienced, and the other one disagreed. So it was actually a 50-50 kind of split, but they had to go with the fact that they couldn't rule out what the expert that agreed had said about the examination that had taken place. And then he was pulled up on multiple different things regarding consent around the whole situation. But yeah, I mean, ultimately it's their decision it's their it's, you know, they've done a proper investigation with officials and everything involved. So
thank you, Danny. Ashley, what type of consent form, or how do you deal with the issue of consent in terms of making a record of consent? You know, how does that work with you?
Yeah, so so the Charter Society of Physiotherapists suggests that if what you're about to do is not kind of that risky, let's say, because I'm a physio, let's say I'm going to, let's say, some exercise rehab or some manual therapy, it's just not really that dangerous at all, not risky, you can do verbal consent. And then if I'd have verbal consent, I get the verbal consent and I write down verbal consent was granted, etc. And I just note that down. If it's more of a kind of risky technique, I then get written consent, such as dry needling or a manipulation, what was a bit more risky. I'd get written consent, but that's how I do things, and that's what my kind of one of my governing bodies suggests to do it. So.
Right, and could you just expand a little bit on dry needling and why that would definitely require maybe written consent and how you might process that? Yes,
because well, with dry needling, you're piercing in the skin, so there's risk of infection. You know, neurothorax, what's going to lead to lungs to collapse, bruising. Patients can change people's blood pressure, so there's a lot can go on. And I just have my own kind of printout, and it tells you all the risks of dry needling, and it tells you everything what can happen, the benefits as well, and then you can sign it if you wish to have it or not. Sorry. Yes. After obviously I've explained why I want to do it, and why it's relevant, and yeah,
getting that continual sort of buy-in and understanding, and where you're left in no doubt that there is informed consent from the clients that you know, the procedure you're about to undertake is accepted, you know, 100% in principle, you know.
Yes, exactly that.
Right. So I know through our membership and through working with BGI UK and BGI EU, we do have a pro forma consent form. Do your modalities have a similar type of thing that's suggested or recommended, a pro forma type of questionnaire and consent form? Robin?
Well, I was going to say that some of these things maybe fall out of expectations and standard practice for many of us. I don't know, that's my view. And I think probably the way we normally approach things is to look in a slightly more circumspect way, because quite often, for example, someone may come in with low back pain, but you find their mid back is the real issue. So you might end up saying, unlike the case just now, which is far more invasive, that we're going to end up treating somewhere that's not the patient expectation of where the problem appears to be coming from and where they're actually suffering. So sorry, that doesn't quite answer your question, but I just wanted to say that sometimes there are different techniques that one can apply instead of something more invasive. There are different parts that can be treated more successfully to alleviate symptoms. And again, even patients may be quite pushy to say, well, I want my low back treated because that's what I come for. So that's something. And yes, and getting people, if it's out of the general standard practice of what I would do, then we would note that and have that written in the notes at the very least to say that we've made a note that something different is going to be occurring. And we do have a section on the back of our case histories where we ask them to agree that what we've discussed, what we've recorded, is a reasonable, accurate representation of the facts that they provided us when we've asked them questions. I mean, the one thing that always comes up is no matter what's been said at appointment number 3, let's say, someone will actually suddenly reveal something they had forgotten completely, even when asked about it, to reveal. So during the chat, that's not just idle chat, one is constantly uncovering new data about your patient as you progress. So there's always something one might be adding to the mix unexpectedly, perhaps, even when you think you've covered everything.
Yes, no, that's very useful. Thank you. Is this different? Is consent different for 16 to 18-year-olds? Danny, I don't know if you have something to say about that.
On our forms, it's anything over 16. Any age over 16 is anything under that is a guardian or parent needs to sign consent. Like I said, capacity. Yes.
Thank you. And when you're talking about specific areas of the body where you've got a slightly more invasive treatment that you're proposing, Robin, you just mentioned that you'd get the client to actually read the consultation notes. Would you get the client to maybe sign them or not?
Well, we do have that option, and if we are entering territory that we find might be contentious, perhaps, or difficult to check their understanding and whether they're fully on board, that would be an option on the page to give them as an option.
Right.
I think the thing is choosing other techniques that are less invasive first of all, and therefore avoiding this particular issue. Or sometimes we refer, I might well refer to an osteopath colleague, for someone who I think might need something more invasive, who does that as their specialty and that's their main part of their work. And then I think they have that system in place to deal with that in a way that we wouldn't. So we make referrals appropriately to people we feel, but on recommendation or word of mouth, that they are particularly good at dealing with a particular area that might be more invasive.
That's very helpful. And a failure to refer is actually a noted area of concern previously in some of the research that has come up from NCORE. So that's really good to hear that you can always refer on and don't hold back from referring on if it's necessary. So, I think that's really an important point to make. Okay, so moving on to Part D, the last part, before we go into a brief discussion on the case study, which hopefully will wrap up many of the topics that we've spoken about. Professionalism. Practitioners must act with honesty and integrity and uphold high standards of professional and personal conduct to ensure public trust and confidence in the profession, or professions, I should say, as we're represented here by a number of professions. Specific areas that we're going to be looking at are note-taking, record keeping, digital and or handwritten, client data requests for data, confidentiality, including data security. NCORE findings have found that a breach of patient confidentiality has been an issue or is an issue to be looked at. Area of concern: data protection management, storage, access to confidential data is something which is causing a little concern at the moment. Just to let everybody know as well that FOIT membership benefits at the moment include a data breach alert service, encrypted and registered emails and digital signatures, a certain proportion per month. And if you want more, then we can offer discounted rates for those. And we also offer additional cybersecurity at discounted rates. So if cybersecurity is or becomes a bigger issue for you, do get in touch either through FOIT or directly to BGI UK or BGI EU. Now, how do panel members store client data? Ashley, could I ask you first?
Yeah, so at my clinic, Anatomy Wellbeing, everything's electronic actually at mine. So the system I have, once you do your notes, you click basically a lock button, and that now can never be edited ever again, and it will get kind of put away. I've been told you should be keeping notes for at least 8 years to keep notes, and that can only I can see that it's on a Mac what is computer and password protected, so no one else should be able to get on it. And there's another password to then look at people's notes. And if I ever leave the room and my computer's in there, there's a button I press what locks the screen, and then anyone's name, let's say it was on the diary page, everyone's name just basically turns off, and you just see appointment. So there's no way anyone can get hold of anything I can see other than myself. And my laptop, I always take it home. I never leave it in the clinic.
Okay, thank you for sharing your data security practices, Ashley. Danny, how do you ensure your data is kept confidential?
So we use a system called Clinico. It's an internet-based system, so it's all stored on their cloud or servers. They have a similar system where you can hide the names, so that's really good to stop other patients seeing what clients you've got. We upload all of our paperwork, we scan it and then shred it. So for patients who can't use the technology, you give out a paper form for them to fill out, and then obviously once they've done that, you can scan it up and then and shred their data. So yeah, it's real. It's just embracing technology really, and trying to keep everything secure. So there's nothing left out available. There's a what's the clean desk policy we have as well. We try and not allowed to have any patient data just lying around, so keep your desks nice and tidy. No leaving sheets out overnight, for the receptionist to do the next day, things like that. You want to, if there's any sheets which need uploading the next day, you want to lock them away. It's crucial to have these policies in place to avoid any risks, just in case the worst case scenario can happen.
Great, thank you, Danny, for sharing your practices. Robin, how do you manage any data, client data requests? Have you had any? And if you have, how would you manage, or if you were to have any, how would you manage the data client request when they request the data that you keep?
We need that request obviously in written form on an email, so that it's not just by phone call. So we have a record of the request and who requires the information. So even if we get a third-party request from an insurer or from somebody wanting information, we have to go through and check that that's been released with the patient's consent, because that's actually quite a trip up that we've had a few times, actually, even from lawyers who've written to us without actually showing us any consent at all from the patient to release anything, which I find quite amazing, but that is what has happened. And I think also we do keep the initial case sheet, we do as a 2-page written case sheet, and we do keep it under lock and key, and that's kept away. The rest is all done digitally online using our booking system, so it's all secure that way. The reason we do the written version, and again, people may say, well, that's not as up to date, but actually on the first consultation, when you're really trying to build rapport and a connection with the patient, I actually find having pen and paper and being there with the patient actually slightly, for me and my colleagues, I think easier to deal with than having a computer screen as well. So it's kind of just a slightly different approach, and we've kept that part in for now. Yeah, so, and I think the other thing is the trip ups also, about appointments, about patients, even phone calls from someone's partner, someone's golf partner, anybody asking to find out why they can't play next week, or why, all sorts of things that you think, gosh, what's that gonna, or is my wife coming here next Tuesday for an appointment, or whatever. Quite interesting how these little trip ups for receptionists and teams, that you've got to be very, very careful that these little things come along out of the blue. So not the big sort of, stealing data off your computer, but actually just those little simple things that are, someone might tell me, a wife may tell me, well, I'm having a baby or I'm pregnant, but you're also treating the husband and they haven't disclosed anything of that sort ever. So therefore, that's not a conversation starter to say congratulations when you see the would-be father. So there's all these little things that come along, and it's actually quite amazing how much detail one has to keep, as well as written or stored, but actually in your mind, just to keep on top of that as a communicator. And it's another level of, well, professional pressure, but there is a professional pressure to make sure that that's kept in mind as well.
Yeah, no, absolutely. Thank you all of you. I do like the membership benefit, actually, the data breach alert service, which I have also installed on my own contact database, so that if any of my contacts are, receive a phishing email, I will be alerted to that. So that's quite an interesting and it's part of the member benefits for Foyt, and it's quite interesting because that will often be or sometimes it will be the first port of call where your system has been compromised, is when your contacts are then contacted directly by a third party. Talking about the Data Protection Act of 2018 and GDPR and the data protection principles, where we must make sure that we only keep data which we have a legitimate purpose for collecting, and that purpose is communicated to the data subject, the client, and that we don't keep that data longer for that original purpose for collecting the data in the first place. So I'd just like to remind everybody about that. Okay, moving on to the case study, where we can hopefully draw a lot of what we've spoken about together. This elderly female client had a complaint of back pain after one treatment with a practitioner. The complaint was that the therapist caused a fractured rib separation injury during an adjustment procedure. There was previous osteoporotic insufficiency fractures experienced and suffered by the patient. And the expert witness acknowledged that the clinical notes were not adequate, in that they did not take any specific account of the client's diagnosis of osteoporosis and did not have any specific reference to consent, funnily enough. Expert report noted that a rib fracture was not a typical risk of the procedure that was actually employed. And the report is also critical of the practitioner's notes and consent form. So do we have any comments on this case study? Please start with Ashley.
Well, sorry, my internet went a bit and it came back, so I just got you a bit there. But yeah, so straight away, obviously he wasn't thorough enough with the assessment, and he should have really kind of dug deep into basically the client's history, and you know, if I see someone with, if I kind of get out osteoporosis of certain patients, obviously I'm not going to do certain techniques, or I'm going to talk about it more, find different ways to try and treat the issue rather than go straight to manipulation. So I just feel like the subjective assessment wasn't up to standard, and his reasoning, their reasoning, sorry, wasn't up to standard as well, because I'm not sure why you would do that, really.
Thank you, Ashley. Danny, do you have any comments on this particular case?
It's always difficult with these ones because context, but the main thing with, especially because she had a history of osteoporotic insufficiency fractures, is to perform a Q fracture questionnaire as well, to determine, is one example of a questionnaire you could give this patient to determine the chances of rib fracture. And that's a freely available website. If you type in on Google Q fracture, and you can do a questionnaire with your patient to determine risks. We've also got a quality standard which the Royal College of Chiropractors has produced. They produce quality standards for various different areas of the profession: chronic back pain, acute neck pain, various ones. And those standards are what patients should expect to receive from the chiropractors, because the Royal College try and promote best practice, and that's one way that they can inform their clinicians about how to approach cases such as these. But yeah, just like as previously mentioned, like Ashley there, got contextually it's tricky, isn't it? Because again, you don't want to kind of come down on the guy without knowing everything, but that's the responsibility of the osteopathic profession itself. But it doesn't sound like it's a great situation on this one.
Yeah, I mean, that's it's a big red flag, isn't it? With an elderly female client and osteoporosis.
Did it state what maneuver was used at all, or not?
It's uncertain at this stage, but it was noted that the rib fracture was not a typical risk of the procedure that was employed.
That's the fascinating part, is how,
yeah,
like, did they just, like, how have they fractured the rib if it was not part of the procedure? Which is where it's confusing when it comes to this contextual fractures, because you could have touched the neck and then the rib fractured down at the bottom of the back. So it's like, what's happened there?
Yeah,
I am aware that the Royal College of Chiropractors has an osteoporosis assessment and management flowchart, which we will not go into, but it's publicly available at the Royal College of Chiropractors, and that goes into some detail as to risk factors and points to note. So, Robin, do you have anything to add?
Well, I think probably giving, again, time to do a case history properly. I know some appointments are very short with some practitioners, and, you know, standard, I think that the Institute of Osteopathy and others would say normally about a half-hour appointment minimum, and some people have longer, and I think you've got to go into these things. But, you know, doing a proper case history, you know, as part of the undergraduate training, I teach lots of postgraduates, that kind of, and I did used to to teach at undergraduate level as well. I think teaching case history taking, you know, is a big skill, and it's sometimes not just a hoop to go through to get to the next bit, which to use a technique, you know, and people do a lot of courses on new techniques that they can add to the toolkit, but actually, you know, getting that detail down. There's certain things you said, the red flag, you know, the minute anyone says this, have you had a DEXA scan? Have you had any follow-ups on that? Because that would be the first part of the conversation, even before anyone touches anything. And the thing in this case, you know, someone could fracture a rib that was osteoporotic, and particularly if it was arterial insufficiency, which is what this implies, would mean that they could just cough, hopefully, you know, or sneeze violently, and they could fracture a rib. So, you know, it's very difficult to attribute what caused what in this case, and obviously we haven't got all the I'll call it the bare bones. We haven't got all the information to go on here. But I think probably, you know, a poor case history taking means probably someone didn't take the time or didn't even ask all of the right questions, and that is really the basis before anything else starts. And certainly as an osteopath, that part of the training, you know, all undergraduates, that's why we spend that time. And sometimes, as we've mentioned earlier, getting a patient on board to say, it's going to take me a bit of time to go through this as part of your first consultation. It's not all about the hands-on, let's get on with it. And sometimes one has to embrace that as well. So,
yeah. Excellent, thank you. Yes, Ashley. Yeah.
I was just gonna say a good point from Robin is really like, if I was a bit like, I'll just say, I'd be honest with the patient and think, do you know what? It's going to take me some time to understand what I can do with you. Or I would then just want basically something in writing from the consultant or doctor who's been seeing this patient beforehand, just to understand what they think as well.
In fact, can I just add a little bit more to add to actually what he just said? I think that you know, getting the appropriate practitioner to do this assessment and take that on board, and indeed, you know, this seminar, this webinar is for manual therapists of all different types. So it's choosing which skills you've got, knowing your limits, and this one, you know, comes into that case very heavily. Perhaps that wasn't well considered, or the history wasn't actually something the person was particularly au fait with doing that properly, and therefore refer to someone who really does know how to do an assessment. And the other thing I was just going to add is that it's very easy on websites to advertise yourself as a person who does treatments or fixes pain, but actually a lot of us underestimate the value or the importance to express the fact that we're there to assess as often primary care practitioners, because people may not have seen their GP about something when they come and see us. So we're there to screen and to make sure the patient's safe to treat. And I think that's the imperative, really.
Absolutely. And I think if there is a heightened risk of this particular client having that vulnerability, I think one of the considerations for patient at risk of osteoporotic fracture is to refer for consideration of investigations, including axial DXA scan and or advice on prescribed medication, and again referring back or referring on, as we've all mentioned or alluded to. I think we're coming to the end of the webinar now, and what's apparent to me, or what has come up for me many times when I've been looking at this material and this webinar, is that fundamental to everything that we've been really talking about is communication. For me, it's communicating with the patient and making sure that that communication is two-way, and that you are both of you on the same page when it comes to what is the ailment, what is being complained of, and what you, the practitioner, would be proposing to deal with that, and just maintaining communication and keeping that communication open, clear, honest, if you like, and continuous throughout the whole process. So I think I'll wrap up here. If anyone has anything else they want to say, this is a good time to say it. Do we have any other final comments from anybody on the whole webinar generally, or should we wrap up now?
Well, just add then that the best practice bit that you put into the beginning was really good, because I mean, we're here because we believe in being professional, and we're supporting, you know, being on this webinar. I think all of us, you know, we don't know each other well, but we've exchanged things, and we get a strong feeling, or I get a strong feeling, that we're all very committed to that. And it's really important to instill in, you know, everybody out there who does manual therapies of any sort, that they observe best practice and really look after the patient's well-being on every level. So I think we're hoping to share that insight.
Yeah,
Absolutely.
I agree. I think, like you say, it's good to strive just to be professional. It's not necessarily the bit which rewards you financially as such, but you will, especially in the professions that we work in, there are times when you are working and things will come up and they will scare you. They'll come out of the blue and it'll really shock you. So if you're not holding those standards highly and you've got nothing to fall back on, ultimately just wrong place, wrong time, it can happen to anyone, and you hear it as well. And so just try and keep those standards up the best you can. Keep keep all those like we saying, all the best practice standards: consent, written, verbal. Keep reappraising it each time. That's all you can do.
Yeah, thank you, Danny and Robin. I think maintaining best practice is a matter of obviously personal and professional, and I don't think the two can be necessarily separated. Personal and professional standards and integrity really important here. So any final words, Ashley?
No, it's about being professional. It's about talking to your colleagues, learning from each other, learning about other people's experiences. Like I've learned a few of Danny's and Robin's just doing this webinar, and even just I think I'm from Peterborough, so it's very multiple. There's lots of different cultures and everything. So I think it's a good habit to try and understand cultures a bit more, so you can communicate them efficiently as well. Because something you might say to somebody would be very offensive to someone else. Or if, for example, you may have a patient who's, let's say, from Muslim background, you may have to be extra careful when even just touching or and whatnot. So yeah, it's just learning and putting that into your practice and being as professional as possible.
Yeah, indeed. And you mentioned Muslim clients and patients. For instance, if you know that your client is observing Ramadan, then you might be mindful of blood sugar levels, during the day, that sort of thing.
Yeah, precisely. And it's just asking them questions. And I've had like, for example, been treating Muslim women before, and sometimes I'm not sure what the boundaries are. So I there's nothing wrong with asking straight away at the start of the appointment, and asking, just what would you be comfortable with? Is there certain things you would not be comfortable with? And then is it best to refer to maybe a woman physio or osteopath, chiropractor, etc.?
Yeah, so remain teachable and be open to, look, you tell me what works for you,
yes,
rather than me tell you how I'm going to do it, sort of thing.
Yeah, I want the patient as comfortable as possible. Yeah,
absolutely. Great. Well, thank you very much, gentlemen. It's been an interesting journey, and your input has been greatly appreciated. And once again, thank you very much for your participation, and thank you all of you for tuning in and being part of this webinar.
You're welcome. Thank you.
Thank you very much.